Hi all, I'm Jen, the Research Director for the Taimaka Project, a joint Nigerian-American NGO that works to treat acute malnutrition in northeastern Nigeria. Within our treatment program, we aim to research and incubate innovative ideas to make treatment better and more cost-effective. Today, my colleagues and I will be talking about our work funded by the Agency Fund to develop and implement behavioral nudges to improve sustained attendance in our program to treat acute malnutrition. Our treatment program uses a community-based management of acute malnutrition, or CMAM, model to provide life-saving foods and medications to children suffering from severe and moderate acute malnutrition. Children attend CMAM outpatient clinics for 4 to 12 weeks until they reach nutritional recovery. While treatment and medications are provided free of charge in our program and in many CMAM programs around the world, many caregivers don't return for weekly appointments. Globally, about 18% of patients default or stop attending before completing treatment and fully recovering from malnutrition. These kids are at a higher risk of death than their peers who do recover. Common reasons for missing visits include high indirect costs, especially transportation costs, limited health literacy, and barriers to information that particularly affect caregivers along gendered and socioeconomic lines.
Hello, my name is Sanjana. I'm currently a pediatrician working in the UK. I've been a research fellow with the Taimaka Project since last year. At the Taimaka Project, we're studying the development and application of behavioral nudges to reduce default rates in our CMAM program. Our nudge is a series of automated voice calls recorded by healthcare workers and sent in local languages to caregivers 1 day before their child's next scheduled visit to the nutrition clinic. The calls are intended to remind and encourage caregivers to help sustain health-seeking behavior over the course of their 4 to 12-week treatment, which ends when the child has reached nutritional recovery. The messages were created based on a qualitative study of health-seeking behavior, trusted messengers, and suggested messages among caregivers of children under 5. Messages were revised on the basis of a pilot study during which 600 caregivers received automated messages. Of these, 200 were randomized to receive messages or not. We saw some differences in default as the final outcome during the pilot. Program-wide, we saw an overall default of 19%, with some possible variation between groups. In May 2023, we will begin a larger RCT to measure the impact of voice calls and nutritional outcomes among 2,000 caregivers.
Today, we'd be particularly interested in this group's feedback on how to measure the marginal impact of the messaging intervention in the context of CMAM's community mobilization component, which is a standard pillar of CMAM programming globally. Generally, community mobilizers conduct household visits to check in on the child and observe the home environment. At Taimaka, we need to unpack the implications of variations in household visit capacity over time. Currently, all children in the program are supposed to get a household visit from a community mobilizer, both after their first clinic visit or their admission visit, and again following any absences from a weekly clinic visit. However, the capacity of our community mobilizers to complete all household visits clusters in time. It's most constrained during periods when the number of new enrollments or new admissions is high, and it increases, that is, the capacity to complete all visits becomes greater during later program weeks, as there are fewer newly enrolled kids to follow up with. Default also clusters in time. Kids are more likely to default or stop attending after 1 to 2 visits to the clinic than during later program weeks. So our question for you is, how can we account for the fact that messaging may delay absences to later weeks, at which point differences in default could be attributed to improved capacity of community mobilizers to complete all household visits, rather than to the automated voice calls themselves? In the field, Taimaka's staff are working to smooth the number of new enrollments over time by capping the number of admissions per facility per day. This could help reduce the fluctuations in capacity of our community mobilizers over time. And we'd be curious to know whether you have suggestions for other programmatic adjustments or adjustments to the design of our RCT that could improve the quality of our data for the study while maintaining community mobilizer visits for all kids who need them. Thanks so much for listening to our presentation today. I'd like to give a huge shout out to our research partners, including Sanjana, as well as Katerina and Jared at the University of Florida, and Hadiza here at Gombe State University, as well as my colleagues Alibaba and Olivia here at the Taimaka Project. Also, many thanks to the Agency Fund for their support in this work. We'd love to hear from you if you have feedback on this work or ideas for our research generally. Please feel free to reach out. I've popped my email on the screen here. And thanks again for listening today. Bye.